right, and then I should probably rename myself during the meeting, and then I can change it back. That's under
Good morning.
Morning, everyone. We'll give it a few minutes to collect folks. Good morning. I have 9:02 on my clock, so I'm going to propose we go ahead and get started. As a reminder, this meeting is being recorded and also broadcast live on YouTube. I think the Zoom gave you the option to opt out and not participate in the meeting as you signed in, so hopefully folks are aware of that. As a reminder, this is the second workgroup meeting pursuant to Public Act 23-171 regarding the 340B program. The agenda was posted on the website, and just to review quickly, we won't do a whole round of introductions again, but we do have some new members, and we'll allow the new members to introduce themselves. We'll have a brief recap of the last meeting, discuss each provision, just an opportunity, open discussion of the provisions of the act, and to see if folks have additional input on those provisions to advise us on what should go in the report. And then we'll finally just cover a few logistic notes on how we're going to gather feedback from workgroup members as we work towards that report. We plan to have one additional meeting that's scheduled in December. Depending on how far we get, we may call another meeting in January. I'm hoping that we won't have to do that, and we'll have all the information we need. And if we have some additional information that we need to gather from individual folks, we can reach out. Folks are always free to email either myself or Joel if they want to contribute content and consider that for inclusion in the report. So with that being said, we'll get the meeting underway. I'm assuming all the technology is all set to go. I know, Joel, if you give me the thumbs up and making sure we're all set with that, then we'll move on to the meeting.
Yeah, I believe so. Let's go ahead.
All right, sounds good. So I know there's at least one new person that's joining us this week, for this meeting, and that's Mr. Bill Smith. Mr. Smith also has a short presentation. I'm hoping, Mr. Smith, you got my message that we'll give you a little time on the top of the agenda for that.
I did, thank you.
Perfect, great. And I think we can share the slide. Either you have ability to share slides directly, or we can share on our end, whatever you
Yeah,
prefer.
I found one error in the slides you sent, so I prefer to share my screen, but whatever's easy. It was one minor
Okay,
error.
that sounds good. On first brush, I don't notice any new members other than Mr. Smith. So if folks want to go ahead and unmute if you are new and did not participate last time, please go ahead and introduce yourself.
I'll go. Good morning.
Okay. Mr. Smith, sorry. Good morning.
Oh, okay.
Can everybody see my screen?
Yes, I believe so. But Laura, were you about to introduce yourself?
Yeah, just because I missed the last meeting. So I'm Laura Manzione. I'm here representing the Office of the State Comptroller. So good morning, everyone. Thank you.
Good morning. Thank you. Thanks for joining. Sorry, Mr. Smith, I don't want to deviate from the agenda necessarily. And I did just notice that the brief summary, we were going to just do a quick recap of our last meeting before you start.
Please.
Okay. Last time, I think folks will remember, but just for a recap, we had presentations from Mr. Drew Gattin from National Association of State Health Policy. I believe he's joining us again, although I can't see everyone on the screen. I saw him earlier, so welcome back, Drew. That was a great presentation, and it really helped us level set a little bit on the program. We also heard a bit from the federally qualified health centers, Connecticut Hospital Association representative, and our own DSS staff in respect to their relation to the 340B program. The recording, if folks don't know, of that meeting is available online, and we're working to get notes for that meeting also posted. Those aren't up yet, but we will get those posted as soon as we can.
No, the minutes are posted.
Okay, so that. Oh, they're posted. Fantastic. Thanks, Joel. Great. Joel, did I miss anything on that recap?
No, I don't think so, but everyone feel free to look at the minutes, and if there are any corrections or additions, feel free to send those to us. It's not intended to be a formal, this is just a work group to advise DSS. It's not like the work group has any official decision-making authority of any kind. So it's really just to summarize the meeting. But again, any inaccuracies or corrections or missing pieces, feel free to send them to Dr. Dalal and me. Thanks so much.
Thanks, Joel. Okay, now we'll turn it over to you, Mr. Smith, with if you can give a brief introduction of yourself, and then we'll go into the presentation.
Yeah, Bill Smith. I'm a senior fellow at the Pioneer Institute in Boston, and I study life sciences policies that affect the entire life sciences ecosystem, not just the industry, but academic medical centers, university research, that kind of thing. There's quite a cluster of that in the Boston area, as you know. And so Pioneer has devoted an entire initiative to studying it. And we've spent about 1.5 years studying the 340B program, and I'll give my view about how it works and what the policy problems are with it. And in my view, the statute was just poorly written. The mission and intention of the statute was very worthy, and I don't advocate cutting the program drastically. I do think the program needs a little transparency, as I'll explain. So where did this program come from? Well, in 1990, Congress decided that the Medicaid program should be required to get the best price from drug manufacturers of any payer in the United States. I think that was a good idea, actually. It tied Medicaid prices to market prices and gave the government the lowest price. But there was one problem. Drug manufacturers had been giving voluntarily about 500 hospitals or so very, very deep discounts because they knew they were financially troubled. And so when Congress required that those discounts be given to all 50 states, the hospitals were concerned they were going to lose those prices. So Congress addressed this issue in 1992, created the 340B program, required drug manufacturers to give these deep discounts to hospitals and certain clinics, and they exempted these prices in the 340B program from the Medicaid best price law. And just for background, the law in general, there are a number of ways clinics and hospitals can become eligible for 340B discounts, but the most common way is that if you served about 11.75% of your patient population was Medicaid, then you can be eligible the next year for 340B pricing. And that's important in the growth of the program. So how does the program work? And this slide, I hope, gives you some sense of how the incentives in the program had become kind of misaligned from its earlier mission. So say a Medicare patient comes into a 340B hospital and they unfortunately have a cancer diagnosis. The hospital may be able to buy a $100,000 cancer drug for only $25,000 at the 340B price. But the hospital can then bill the Medicare program at 106% of average sales price, which is what the Medicare reimbursement rate is, or about $95,000. So in that one example, the hospital profit on that one prescription is $70,000. So essentially what's going on is the hospitals are arbitraging the 340B discounts, meaning buying low and selling high. And they do this with commercial patients as well as Medicare patients. And notice for the uninsured patient or the low-income patient, the hospital doesn't make that any significant profit. They buy the drug for $25,000. If they give it away for free, they lose $25,000. If they charge the patient $25,000, they get zero profit. So the program has incentives in place for hospitals to arbitrage the discounts in the 340B program. And this slide just shows the incredible growth in the program. 2015, the light blue bars are purchases made in the 340B program at 340B discounted prices. So it was $12 billion in 2015. and it is now more than 50 billion in 2022. The dark blue bar is what hospitals would have paid had they purchased the drugs at the list price, the wholesale price. And again, this program is now at a whole list prices. They would have paid $106 billion in 2022. So this program will soon become the largest federal drug program. And the most concerning policy issue in my mind is that as this program has exploded in growth, and again, the mission of the program was to support hospitals serving low-income and uninsured patients. As the program has exploded in growth, and you'll see 2012, 6.9 billion in discounted purchases, charity care as a percent of operating costs for many 340B entities has been declining. Now, that's not the case for every hospital and clinics generally are pretty good about giving charity care, but as a general rule, 3.6% of operating budgets were given as charity care in 2012, and that's down to 2.5% as this program has exploded in growth. So I'm not going to go into these details in the slide, but basically the New England Journal of Medicine and a bunch of other very authoritative sources have pointed out that charity care has been declining as 340B revenues have been growing. So what we decided to do is create a web tool. And the web tool has 3 components, and I'll explain each of them briefly. But the first component is you can see how quickly 340B has grown. The second tool, which this group might be quite interested in, is you can go into any state legislative district in the country, assembly or Senate district, and see the number of 340B participating entities in that, clinics, pharmacies, and hospitals in that particular clinic. And that mapping tool is important by legislative district because you can see overserved areas and underserved areas. You can see wealthy assembly districts having a robust number of 340B entities and poorer districts having fewer 340B entities. And lastly, the third piece of our web tool is hospital charity care. And you can go on that site and see any hospital in the 340B hospital in the country, and you can see the level of charity care they've been providing over the last decade. For that particular part of our mapping tool, our web tool, we purchased data from the RAND Corporation. Hospital charity care reporting is a little bit uneven. Some hospitals report certain things as charity care, others do not. And so the RAND Corporation has tried to even that out. They've been working on this for decades, and they even out the data. So we went and purchased that data, and we consider it pretty reliable. So this is a slide from the first part of our web tool that shows growth. You'll see the number of participating hospitals and clinics has grown from 38 in 1992 when the program was created to more than 3,000. The number of contract pharmacies participating in the program has grown from 8 to more than 30,000. And part of that is due to the fact that HHS around 2011 lifted the cap on the number of contract pharmacies that each hospital could contract with. This is the second part of our legislative tool. Again, you can go to any state assembly or Senate district in the country, and you can see the number of 340B entities, both pharmacies, hospitals, and clinics. So you can map out areas that might be underserved and areas that might be overserved. To prepare for this presentation, I looked at Senator Summers' district, 18th Senate District, and there are 14 340B entities, 10 pharmacies, and 4 clinics. Then I looked at Bridgeport, which is not too far from where I live, which is generally a lower income area, at Senator Gaston's district, the 23rd district, and I found that they had fewer 340B entities than Senator Summers' district, only 13, 9 pharmacies, 2 hospitals, 2 clinics. So you can use this tool and discover that some areas are overserved and some are underserved. That's not the case in every district, but it is the case in many. You can also use this tool to see the exact number of pharmacies and their address in each district and the names of the pharmacies. And in general, what we've seen, and the bar chart on the top shows the average charity care of all 340B hospitals in the country. You'll see in 2011, it was close to 4%. It's down around 2% now. And that's problematic given the growth in the 340B program. You also can look at individual hospitals. If you look at the bottom of the slide, you can look at any individual hospital, the 340B hospital, and see what their trends in charity care spending. And what you'll discover is that there are some hospitals, look at Queens Hospital, 17% of their operating revenue is going to charity care. And there are some hospitals really doing the right thing. And there are some hospitals, and I won't name them, in Massachusetts, for example, that are very wealthy, have big endowments, and are spending less than 1% of their operating revenue on charity care. So, but you can use this tool to discover who's doing well and who's not. This is my second to last slide. And basically, what it shows is the number of pharmacies in higher income areas versus lower income areas in 6 states. And the dark blue bar is upper income areas in the states. And the lighter blue bar is lower income areas. And what you see is in Massachusetts, Louisiana, and New York, for example, there are more 340B pharmacies in upper income areas in the state than in lower income areas of the state. So that's a problem. But even in the other 3 states, Illinois, California, and Virginia, the number of 340B entities in lower and upper income areas is about the same, which in my view is also problematic, because that light blue bar should be much higher. There should be many more pharmacies in the higher poverty areas. Okay, this is my last slide. So what can states do to reform a federal program? This is a federally federal statute that created this program. It's a federally run program. So I kind of see 2 problems that states potentially could address. There's uncontrolled growth in the program while charity care declines at the same time. And the entire purpose of this program was supposed to be to serve lower income and uninsured patients, sometimes through charity care. So states, because nonprofit hospitals sometimes have to make certain filings with departments of revenue in the states, in my view, the first thing that should be done to reform the 340B program would be to require that these hospitals in particular disclose exactly how much 340B revenue they've made in the year before, and how much, under a uniform definition of charity care, how much they spent on charity care. I think if those 2 things became transparent, states could know which hospitals are doing the right thing by their community and which ones are not necessarily. I recognize there are many hospitals that are struggling financially, and so I would not advocate cutting the 340B program right out of the box. I think the best thing to do initially is some transparency to discover who might be doing the right thing. And the other thing is that wealthier areas tend to be overserved by the 340B program, and lower income areas sometimes are underserved. That in part is due to the fact that because the hospitals can arbitrage the discounts, they tend to open satellite offices in upper income areas where patients might have very good insurance. But this is a reality. We've seen it when we played around with the tool that wealthier communities tend to have more 340B entities, tend to, not in every case. So you could use our tool and have your staff play around with it and discover the underserved areas in Connecticut and the overserved areas. Look at wealthy communities and how many 340B entities they have, and lower income communities and how many 340B entities they have, and just provide some sunlight to that. So that's my presentation. But the web address, which you'll see, I'm happy to share these slides with the working group, but the web address for the 340B tool is on this last slide, as is my contact information. I'm happy to answer any questions.
Thank you, Mr. Smith. That was a very informative presentation. And at the top, I failed to acknowledge that, Mr. Smith, your name was recommended by Senator Summers, so I appreciate that connection so that we have this perspective here. I want to go to a couple hands that are up. We do have a few minutes for discussion. Senator Summers, I see your hand up.
Yes, good morning, and thank you for that presentation. If we could go back to really, I think it's important because I'm not sure that everybody on this group understands or is clear, because it was even fuzzy to me, and I come from this industry, so to speak. When the hospital is billing in a 340, if they're in a 340B area and the hospital, a person comes in, can you go through step by step how the billing works, how they are charging the patient the price versus what they're buying the product for, so that it's clear for everyone? because I think that's really confusing. It's confusing for the legislators. I've tried to explain it time and time again, but no one seems to get it. Even our Office of Health Strategy, when we first sat down with the bill that I originally said was, in its original form, was something for everyone to hate, and at the end came out with transparency and what we're going to do going forward, but they were confused on how it actually works. So I think it's, if you could explain that to us in your words, not mine, so people, you're an independent person, so they will believe what you have to say. I think that's really important on how the billing occurs.
Yeah, well, the statute doesn't require that patients be, and that's part of the problem of the statute, that patients be given a certain price. What happens is hospitals can go out and purchase the drugs at 340B prices, and there's a formula for that. There are required discounts, and the discounts are significant. In fact, there are some products in the 340B program that are considered penny products, where the hospital can purchase them
15 cents.
Yes, can purchase for a penny. Yes. So then the patient comes in, and the patient may have Medicare or may have commercial insurance, and then the hospital can bill that payer whatever their normal rate is. So right. If the hospitals bought the drug, as I said, for $25,000, and the Medicare rate is $95,000, they can pocket $70,000 on that one prescription. What the patient pays, again, is not in statute.
Right. I wanted to interrupt you on that, because even commercial payers, so I'm going to pick on epinephrine because I do know that the 340B price is 15 cents. So the hospitals are buying it for 15 cents. Even if I have state insurance and I go in and it's $400 or $500 for that epinephrine pen, they're billing the state of Connecticut for the $500 for the epinephrine pen, but they're paying 15 cents, even on a patient that is commercially insured. That's yes. where I think one of the big problems is. And then they take that money and use it wherever they want. And has not been transparency. They're supposed to use it to help the, underinsured and do good for the community, but there's no legislation until recently that has them have to show where that is. Originally, from my understanding, the 340B was not intended for like commercially insured patients. It was for the underinsured or the non-insured patient, but it has morphed into something totally different. And it's very hard to explain. Is that correct?
Yeah, again, Senator, the problem is the statute didn't say which patients are served. There's no definition of patients in the 340B program.
Original intent was not to be able to totally discount these drugs for people that were commercially insured. It was for those that were underinsured, so the hospital could then use the differential to help those that were underinsured. And that's how the program has completely kind of gone off the rails. But I just wanted to make sure everybody understands that, because it's really confusing. Maybe everyone did understand that, but it's really hard to explain that to legislators. Thank you. That was my first question. My second question was, when you talk about on the slide that talked about the wholesale price versus the list price and the differential, hospitals were paying $53 billion in costs for drugs. It really would be $106 billion if it wasn't for the 340B program. Is that wholesale or list price that you were referring to?
That's list. So they wouldn't be paying 106. They'd probably get some discount off that. So they might be paying 100, they might be paying 90, but they would be paying significantly more without the 340B discount.
And this is one of the reasons, this confusion and how it has exploded, that pharma has actually teamed up with like FQHCs to try to, there's actually a group called Save 340B, trying to save the program because it can't continue the way it's going. So I just wanted to make sure everybody understood that. I don't want to overstep, but it's very confusing. Maybe everybody else on this call gets it completely, but trying to explain it to legislators, even to the Office of Health Strategy last year, was really difficult. So I'm glad that you were able to confirm all that. That's all I wanted to say. Thank you.
Thank you, Senator Summers. I just want to draw folks' attention to the hand raising function. So I know that those are some important points that were raised. So if folks want to contribute to the discussion, please raise your hand. I see Guy next with his hand raised. So Guy, go ahead.
Great. Thank you very much, Mr. Smith. Really helpful presentation. Guy Woolston, Medicaid Director here. Quick question on your solution slide. I think it was your final slide. You had two. Your second solution used Pioneer's 340B web tool to find underserved and overserved areas in your states and hold hearings. Makes sense. I'm tracking what you're saying. Just imagine a state were to do that, given it's a federal program, what would be the net of that? That would be creating transparency, and then just walk me through kind of if a state were to hold hearings, what impact that might have. If you could.
Yeah, so let me just use one example. When I was playing around with the tool, I was curious about Pacific Palisades in Malibu. There's an assembly district in California that has two of the wealthiest towns in California, and it's in one assembly district. And I looked at the number of 340B entities that they had in that one assembly district, and I compared that with the number of 340B entities in South Central LA, one of the poorest areas in California, and discovered that Malibu and Pacific Palisades had more 340B entities than South Central. So there's not much a state can do about that. It can't force the federal government to pour more resources into South Central, but it could expose it and bring a little sunshine and have a congressional hearing and say, you know what, you're underserving this one area, even a field hearing or something like that. I just want to bring attention to the fact that this program is off mission. Its mission was to serve lower income areas, low income people, and uninsured people, and give entities that treat those areas more resources. And it's really become dysfunctional, and the original mission is not being carried out, in my view.
Thank you. Very helpful.
Mehul, can I for some reason I cannot find the raise hand.
Oh yeah, sure.
So I'm sorry.
You can raise your actual hand.
Raise my hand. Paul Kidwell from the Connecticut Hospital Association. So I obviously have a point of view on this particular program, but I just, for folks on the call for transparency purposes, can you just describe a little bit where the funding comes from for this project for the Pioneer Institute?
We get money from individuals, foundations, and from industry.
Okay.
Yeah, we do get industry money. There's no doubt.
Yeah, on the website, it just describes.
For disclosure, I'm a former Pfizer executive. I worked at 5-10 years, went back to school and got a PhD in my 50s. And then what else do you do with a PhD except join a think tank?
No, I appreciate it. I just want to make sure, because we're all understanding the point of view that's being represented.
Any other, and I apologize because it does seem like my connection is unstable. So if for some reason I'm glitchy on your end, that's some connectivity issues on my side. So we have Sabrina, who's next, followed by Joel.
Hi. So as a representative for FQHCs in Connecticut, I just want to remind everyone that kind of what this presentation highlights and what we're seeing on like a federal level is that the misuse of 340B funds is not happening at the FQHC level. It is more kind of geared towards hospitals, but the way that drug manufacturers are limiting 340B resources, they are making kind of blanket statements that are affecting all types of covered entities. And FQHCs, which really do function to help underserved and uninsured patients, are also suffering. So that presentation by Bill kind of does highlight it. And I just want anyone who does go to the Pioneer Institute to look up their tools, just keep that in the back of their mind, that you know, if you can isolate hospitals versus non-hospitals, which I do see, we just need to have an idea of what the percentage is, right? So an example for someone that comes to our pharmacy, Senator Summers, for an EpiPen, if their insurance is charging them $400, it's $5 for them. So we're taking that 340B savings and passing it directly to patients. And I believe that most FQHCs are doing that if they have the ability to, but we're again restricted. So now a patient is unable to utilize our contract pharmacies So if someone doesn't live in our direct proximity to our in-house pharmacy and they live, say, in Vernon, where we don't have a pharmacy, they go to a contract pharmacy that we have established, and it's going to be $300 for them. So we're restricted in that sense, and that's what those drug manufacturers are doing. So just, again, I urge everyone to kind of keep FQHCs in the back of their mind, and think about what these drug manufacturer restrictions are in fact doing. It's not just targeting hospitals where we see most of the, or we believe that most of the misuse is happening, but it is really affecting those uninsured patients on an outpatient level as well.
Thanks. Joel?
Great. As Dr. Lyle introduced, I'm Joel Norwood, Deputy Policy Advisor at DSS. Mr. Smith, just quick question based on your recommendations. Have you seen states, or I suppose potentially municipalities, that you think were particularly effective in trying to take action to make some of the changes that you're recommending? And related to that, have you seen anything in terms of any state successfully changing the dynamic for Medicaid reimbursement of 340B drugs?
I haven't seen any successful. I know there are some bills on Capitol Hill that would require more transparency in the program, and I would support that. But I think that states may have a role in accelerating transparency also. I just think individual hospitals should report on the revenue that they receive and the charity care that they give out every year under the 340B program. I think that's a good first step. I know of community hospitals in Massachusetts, for example, that are struggling enormously because they have low Medicaid reimbursements, high Medicaid patient populations, and they depend upon the 340B program, and I respect that. But I'd like to see what their charity care numbers are and what their revenue numbers are for the program. And I haven't seen states enact that legislation.
Thank you. Senator Summers?
Yes, I just wanted to add one thing quickly. When there was some discussion about the FQHCs, although I would agree that they do help and provide care for low income, I think it's imperative that they also open their books, just like the hospital, and disclose how the money is being used, or the money from the 340B is used to go back into the system. I think it's imperative that we have clarity and transparency in both areas, not just the hospitals. I think that's an important distinction. We were able to pass a bill this year requiring some initial transparency, but the FQHCs were left out of that. They were originally in, and there was a big push to pull them out. So I think that's important to have that transparency also. And I do hear the issue that you're having because you don't have a pharmacy within the area of Vernon, or the area that the people travel to. And that's something that definitely does have to be worked out. But I just wanted to put that in, that I think if we're going to ask for transparency, it needs to be across the board, regardless of who the entity is. Thank you.
Thank you, Senator. Drew?
Yes, thank you. Just wanted to chime in really quickly. First of all, I want to tell Mr. Smith how much I appreciated the presentation. And for folks that were on a few weeks ago and saw the presentation that we did from NASHB, a lot of the data obviously, aligns very, very closely with the data that Mr. Smith presented. And again, just sort of follow up on the senator's comment and Joel's comment. There were 3 states this year that did pass some kind of transparency legislation. All 3 bills were very different. There was legislation passed in Minnesota, in Maine, and in Washington State as part of the budget bill. I think I talked briefly about that in the presentation last time. And if it would be helpful to the group, I could provide the actual language for those. The bills are all very different, but they really are similar in that they're trying to get to the essence of state trying to shine some light on this, as Mr. Smith described in his recommendations. Thank you.
Thanks, Drew. I think that language would be very helpful for this group to have as a reference point and potentially include in our report. So appreciate anything that you could provide.
Yeah, easy.
Yeah, and I apologize for the error. I've been referring to Bill as Mr. Smith, but he referenced the fact that he had a PhD. So I apologize for that.
No.
Dr. Smith.
The doctor is the one who draws blood for me in my physical. It's you can call me Mr. It's fine.
Just a program note. We're about at 9:40, so we have 20 minutes left. But I do want to note that all this discussion we are having does fall squarely within our agenda item 3, which we were hoping to take the bulk of this time to discuss anyway. So happy to spend a few more minutes on this item. All this information is useful, of course, as we are tasked with assembling a report. So this back and forth is actually quite helpful for us, and hopefully it's helpful for others to improve understanding of the program. Any other discussion on, now I can't say Mr. Smith anymore, sorry, Dr. Smith's presentation.
Well, I just wanted to note that Paul Kidwell from CHA just put a note in the chat. Paul, do you just want to say something briefly about the...
Oh, sure. Hospital charity care and community benefit is reported every year to the IRS for not-for-profit hospitals. CHA takes that information along with underpayments for Medicare, Medicaid, charity care, and other community benefits and reports it annually. And I dropped our most recent report into the chat that's available on our website as well publicly.
Okay, if there's no further discussion on this item, I think we were aiming to discuss the other provisions of the item. So we'll just take of the language in the bill. So we'll just take a few moments as part of an open discussion. If folks have any comments or other information they'd like to offer on the other provisions of the bill, if helpful, either Joel or I can put the language on the screen. It seems like that would be helpful as a reference point. Joel, I have it ready to go if that makes sense, unless you have it. Okay, there you go. Joel has put it in the chat. So people can take a moment to look at the language, and if they have anything to add on any of those provisions, the floor is open.
And if it would be helpful, we can also just quickly go through one by one and see if anyone has anything to add.
I think probably for the sake of time, we can, I think as we've told the group before, it's an open invitation to provide information on any of these provisions, either during or between meetings. So folks have the language, and if they want to provide us some additional information offline, that would be fine. I think, Joel, you had a preview of something that we'd want to discuss next time that would fall under agenda item 3. Is that correct?
Right. So I would defer to Assistant Attorney General Trish McCooey.
Okay, thank you, Joe. Good morning, everyone. At the next meeting, the Office of the Attorney General has proposed to do a brief presentation on our office's involvement over the past several years on 340B issues. That would entail, on the federal level, Attorney General Chong was the lead author on amicus briefs submitted in several of the federal cases. on the contract pharmacy issues. Our office also led the response by a number of attorney generals across the country to a request for information from a bipartisan group of US senators. And that response went to the senators in July of this year. In addition, although it's mostly, as we know, a federal program, the states are obvious key stakeholders in the program. So the Attorney General's office has also been closely monitoring state litigation in which there have been federal preemption and or ERISA preemption challenges to different pieces of state legislation. So we would also describe our efforts in monitoring that. So it'd be a brief recap of our involvement in these issues on those levels.
Thank you. Appreciate that.
Sure.
So we'll more to come at the next meeting. Joel, do you want to say anything about agenda item number 4, the process for gathering feedback from work group members? I think we had discussed the possibility of just putting together a document and an outline.
Yeah, of course, Dr. Dahl. So some of these provisions are quite specific and really beyond the scope of DSS having easy access to information. So in order to be able to prepare the report required by the statute, we are really hoping that all of you, as well as your colleagues and people or entities that you work regularly with, can provide DSS with some of at least background information on each of these provisions. Obviously, we've had 2 presentations and some extensive discussion on the current status of the program and broad national efforts, as well as discussion of, in very general terms, of potential opportunities for state action. But we really haven't heard much of the others, and particularly several of these are very specific to FQHCs. So we're particularly interested in, hopefully, we'll work offline, but very interested in having a little bit more detailed presentation on some of those remaining pieces. And in addition, our plan is to put together a very short outline, just going through these provisions, sharing it with everyone in this group, and asking each of you to contribute your thoughts to it. Please keep in mind anything that you send to DSS, particularly in the context of this group, please assume that it will be shared publicly. So only put information that you're comfortable sharing publicly. Don't include anything proprietary or confidential. That's the process that we'll hope to go through between now and the next meeting, and hopefully that will be an opportunity for further discussion as well. But I don't know if anyone has any reaction to that, or if you have a sense of what information you have readily available and what sort of time frame and what sort of materials that might be. And I'm particularly interested in hearing from the FQHC and hospital representatives, but really anyone on this group, feel free.
Joel, it's Paul from the Hospital Association. Our plan, I think, is to put together a more formal letter presentation that we will send around to the group and to all of you to describe our, obviously, point of view and interests.
Great, thank you. And then in addition to your general thoughts, if you could specifically address each of those provisions, that would also be particularly helpful.
Yeah, I think we'll just, the legislation is written obviously more geared towards FQHCs, but much of what is outlined here are items that we also have an opinion on, so we'll make sure to address those items.
Great, much appreciated.
And I can reach out to CHCAC to see if they have an opinion that they're able to share, representing all of the FQHCs in Connecticut, with the exception of CHC Inc. So I don't know if they want to do something separate on their behalf.
That would be helpful. And for both you and for Felipe from CHC Inc., as well as Paul from CHA, if there's anyone else from your organization, or in your case, someone else designated by CHC Act, feel free to invite an additional person or two if that would be helpful. But I think given that several pieces of this legislation were specifically geared toward FQHCs, that'd be very helpful to get some more of that background, as some of this is quite technical. Oh, thank you, Felipe. Felipe, is there anything else you'd like to say about that? Okay, I'm just noting that. Oh, he's just noting in the chat that his connection is unstable. No worries. Dr. Dewell, back to you.
Sure, I am experiencing the same issue as Felipe. So a lot of what the last discussion got cut out because of my connection. So Joel, if you can hear me, please, if you don't mind wrapping up the meeting, that'd be great, because I'm not getting the right connection here.
Absolutely. So we'll put together, as Dr. Dewell mentioned, and we were just discussing, we'll put together just a very brief outline framework. So feel free to respond in that context. Feel free also to share any additional presentation. And when you do, if you'd like to have time on the agenda for the December 19th meeting to present about it, please let us know. We'd certainly welcome that. And in addition to FQHC's Hospital Association, is there anyone else who, and the AG's office, is there anyone else who plans to submit additional information and or would like to be able to present at the December 19th meeting? Okay, hearing none, but feel free to reach out later offline. We're certainly happy to do that. And the last thing is, does anyone else have any other topics that they would like to make sure are addressed at the next meeting, which might be our final meeting?
I just concur with Trish's suggestion related to the information about sort of legal actions across the state, I think, or across the country. I think that would be helpful context for actually part of this legislation, which I think subsection 2 and 3, I think, are relevant to that legal action.
Great, that sounds good. And just to confirm, is your understanding that that would be part of your office's presentation on December 19th?
Yes, it will.
Great, sounds good. All right, last call. Any other topics besides those we've already covered? Okay, hearing none. Any other comments generally before we wrap up? Okay. This meeting was officially noticed from 9 until 10, so I will leave the Zoom room open and the live stream continue to record until 10, but for all other purposes, given no other additional comments, we'll wrap up now, and feel free to sign off, but I'm just explaining why the meeting will be open and the live streaming will continue until 10 o'clock. All right, well, thank you, everyone, and please do send us your feedback, and we'll be in touch shortly with a framework for people to contribute their thoughts. Great, thank you again.
Thank you.
Thank you.